All right, for the sake of time, we'll go ahead and get started. Hello, my name is Andrea Estrada, and I will be facilitating the webinar today. I would like to welcome you on behalf of the UC San Diego Parkinson and Other Movement Disorders Center to our overview of CBD and PSP webinar. Each month, we have had a virtual session on different topics related to Parkinsonism and living well. Our hope is that you have learned, and today will learn something new, and find this information relevant and useful in your day-to-day lives. Today's 1-hour webinar will include a talk by Dr. Irene Litvan, the director of UC San Diego's Parkinson and Other Movement Disorders Center, followed by rehabilitation strategies presented by Corey Troyer from the Parkinson and Other Movement Disorders Center at UC San Diego. A few things to note. This is the final educational presentation that our center will hold this year. Sessions will be recorded and available online at movementdisorders.ucsd.edu. And as soon as we find the dates for our 2024 presentations, we'll go ahead and have them posted there as well. We are happy to share any links or resources shown during this presentation with you. We will also send a post-session survey for you to complete. Your feedback is so important and helps us plan for future programs. So thank you for that in advance. Lastly, there will be about 10 minutes at the end for questions. So thank you so much. Now let's welcome Dr. Litvan.
Good morning. Today is a beautiful day in San Diego, and I'm so glad and happy that you're all here. So you'll learn something about diseases that are not Parkinson's disease. Today, we'll talk about Progressive Supranuclear Palsy, PSP, and Corticobasal Degeneration, CBD. So before I'll talk directly into these diseases, I just want to remind you that a typical Parkinsonism or Parkinsonian disorders, that is, disorders that are not Parkinson's disease, have as characteristics two of the same features as Parkinson's disease: slowness with either tremor or stiffness. And what is different in a typical Parkinsonian disorders is that postural and gait instability that initially was considered as part of Parkinsonism, it is of Parkinsonism in general, but not of Parkinson's disease. And more importantly, there are other features that when we see them, we say, oh, they are red flags for Parkinson's. That is, things that make us question, is this truly Parkinson's disease? So when we classify the disorders, then we have all the Parkinsonian disorders, that is, those that have slowness, as well as stiffness and breast tremor. And we have also divide those into neurodegenerative diseases, that is, diseases in which we truly don't know why they are caused nowadays. Some of them may be genetics, but the majority of them are not. And secondary, when we truly know what are the causes of the disease. For example, when someone is taking medications, that's when we ask, what are you taking? And that's why it's so important that you bring all your medications to the clinic, because perhaps one of them is the one that is causing you the Parkinsonism. And that could be, for example, Reglan, a common medication that is given for nausea. It could be that you had an accident, a vascular accident that you may or may not know. It could be that you had an infection, like the West Nile virus. Usually that it doesn't happen in California. It could be that there are other causes, such as what we call metabolic, that is Wilson's disease, or there are toxic causes, at times even pesticides. But in PTP, that was something that occurred many, many years ago in San Francisco. And that was kind of like what it was initially thought, oh my God, this is a new environmental problem. And it was. People were taking this, what it was supposed to be one of meperidine, and they just did it wrong in a lab. And so people got toxic, and because it killed all the cells that were related to the pathways that are motor, and they developed this Parkinsonism. It could be tumors, etc. Or neurodegenerative, as I said, and the main one is obviously Parkinson's disease. That is like 80% of the people that have Parkinsonian disorders. But Parkinson's disease has only the slowness, the stiffness, or may have as well the tremors at rest. But the typical Parkinsonian disorders, as I told you, have different things. And they have been classified in multiple system atrophy that I will not discuss today, PSP, CBD that I will discuss, dementia with Lewy bodies that I will not discuss, and some other familial diseases that again will not discuss. But what has been very important is that in the last years, we have learned what are the proteins that deposit into the brain. And so that is what we call the molecular classification. Now we know. And those could be, for example, alpha-synuclein in multiple system atrophy, or in Parkinson's disease, or in dementia with Lewy bodies. There are differences there that, as I said, that I will address another day. But today, we'll discuss the PSP and CBD, and the protein that deposits is tau, the same tau or similar tau, not exactly the same, as occurs in Alzheimer's disease. But in Alzheimer's disease, there is another protein that deposits that doesn't deposit in PSP or CBD. And that is why nowadays we have so many therapeutic trials, because pharmaceuticals companies are realizing that when there is only one protein that deposits in the brain, it may be so much better and so much easier to be able to slow the disease progression by trying to make that protein not to function or decrease the amounts in different ways. As I said, there are these other diseases with other proteins that deposit. So when we look at studies that look at the diseases when people have passed away, we realize that these diseases, PSP and CBD, are usually misdiagnosed, that people, even neurologists, less movement disorder specialists, much, much less, misdiagnose them as having Parkinson's. So people think that they have Parkinson's and they wonder, why? Why do I have a disease that is different than this other person that I know and has a different course of the illness? And maybe they're doing so much better than I am. So these people may only be diagnosed as corticobasal degeneration in a quarter to half of the people that that have the disease. So there is really a major problem when people just go to the primary neurologist and they never visit a movement disorder specialist when the disease is not going well. The survival of patients that have these diseases, PSP and CBD, is shorter, unfortunately. It's much shorter than in Parkinson's disease, and the quality of life is also worse. And the worst part of the story is that we don't diagnose the disease early, because when people come to us as movement disorder specialists, usually half of the course of the illness has passed. And so they come late. And if they come late, there are less things that you can do and less possibilities to participate in therapeutic trials, as I'll discuss later. One of the problems in diagnosing these diseases is that to diagnose them, we would have to have markers. And truly, there are not real, very, very good markers. At times, an MRI or a PET scan may help, but we're still trying to find PET imaging or even find in the spinal tap that tau protein that deposits in the brain and it can be recovered in the spinal fluid that is different than the one that is in Alzheimer's disease. So the tests that help for Alzheimer's disease only can help to rule out Alzheimer's disease. That is also important, particularly when someone has corticobasal degeneration. So why do we say, yes, we want an early and we want a real accurate diagnosis? Because you want a good prognosis, and we do too. We want to give you the best possible management of all your symptoms. And if we don't have a possibility of seeing you, we will never be able to do that. And we can never offer you to participate in therapeutic trials if you come so late that you don't meet the criteria to enter into a study. So when is it that we need to suspect these diseases? When you are thought to have Parkinson's, but they give you levodopa or other similar medications that are dopaminergic agents, and you don't respond at all, or you respond minimally. When you start falling, when you have a severe postural instability and you just started the illness. That doesn't happen in Parkinson's. It happens at the end of the disease, but not early on. When you have a very rapid progression, you start and then suddenly you start realizing that your speech is really severely impaired. That doesn't happen either in Parkinson's disease. When you have problems with the movements of the eyes, as I'll show you later, when you have severe problems with your speech, with your swallowing, and that occurs very early. When it is in Parkinson's, first of all, it's not extremely severe, but if it occurs, it's late in the course of the illness. When we have severe abnormal posturing, that I'll show you examples of that, and when we have what we call ideomotor apraxia, that is a very strange word for you, but it means that it's like we lose the ability to know how to manipulate objects. It's not that the object falls, as it may happen in Parkinson's disease, but it is like we don't know how to use well a toothpaste or we don't toothbrush, I meant, or we don't know how to fold the clothing, or things that you normally have done. Or like one of my patients said, he was a policeman and he couldn't remember how to use a his gun, and that was his first symptom. He has been a policeman for many years, and now he's not able to use it. He doesn't even know how to do that. Or when you have severe or minimal language problems, when we start not being able to talk, when we have very difficult or we have a lot of difficulties calling or talking, that we have to answer with very short sentences, or we forget the name of things. Not what happens as we age, that there is some difficulty with names, but eventually that happens, that is resolved. Here, the problem is more significant. Or when we have what we call frontal dementia. What is frontal dementia? Frontal dementia is when we lose the ability of doing things that like an executive would know how to do. For example, planning, sequencing, what goes first in a recipe, what do we do that recipe? We don't know how to really manage that. When we cannot multitask. So when the things are severe enough, as they are really affecting the ability to perform a normal life. So how does PSP in particularly presents? So there are several forms of presentation. The classical one, the one that was first described many, many years ago for Steele, Richardson, and Olszewski, and that's why it's called at times PSP Richardson, is when people start with early postural instability and falls. Then they may notice that when physicians give them medication for the Parkinsonism, that is not usually too severe, but is there. There may be slowing, particularly in walking. The medication doesn't work at all. When they start noticing that they cannot move their eyes well, and that is noticed when they cannot look down, they're having problems reading, following the lines. When the speech and the swallowing problems occur very early, or what I mentioned about the
your main problems.
This is an example.
Well, I fall a lot, and I lose my balance, and I don't have any speech, and I write terrible.
What was the first problem you had?
Fall forward.
Is there anything that makes you fall easier?
If I turn quick and so with the help of a walker.
And besides balance, what other problem?
My speech and my writing.
Are you as outgoing as you used to be?
No.
Are you depressed?
No, I'm not. I put too much in my mouth. I can't see very well. I can't read the papers.
Can you read the headlines?
Yes.
Look to the right, look to the left, right, left, to the ceiling. Very good. All the way down to your feet, all the way down.
See, she has difficulty
Okay,
doing that.
all the way up, all the way down. The camera, my finger, the camera, my finger, the camera,
So she has
My finger.
difficulty doing this
the
movement.
fingers here. If you were counting them, thumb, index, thumb, index,
So you
Her
can see
neck,
that there's a lot
here.
of difficulty.
to the thumb here. Index, thumb. All right.
You see how
Now
slow.
thumb,
Now
Index,
the patient cannot move the eyes
Thumb.
up or down.
index.
They can see
All
well,
right.
but they cannot
Now,
move the
I would
eyes.
like you to look at
So that is one of the first forms that was described, but there is a form in which people have like Parkinson's disease. So they start with the forms of having one side affected, and they respond to levodopa, but not really very much. And, you know, a few years later, they develop the falls and they develop the eye problems. And that's what is called PSP Parkinsonism. There is one that is called freezing of gait because the patients get like stuck to the floor, and that is the main symptom. There is almost nothing else. I'll show you an example of that. And there is these others that have the frontal dementia or this form of like corticobasal degeneration, but because it's not really corticobasal degeneration, because it is the underlying pathology that what we see when we look at the brains is PSP, it is called corticobasal syndrome. So here is this patient that has this freezing. You can see the difficulty she has turning. And we put two chairs because what she says is that in narrow spaces is when this happens. This obviously can happen in Parkinson's, but in Parkinson's, usually this responds to levodopa, and there are no other problems in general that are like what you see in PSP, and more importantly, there is the involvement of the upper extremities in significant ways. And here, that is not the case. This is a corticobasal syndrome. That is, you can see the symptoms are on one side. However, this patient was described as having PSP. So how is it that corticobasal degeneration presents? Because corticobasal degeneration can present with multiple forms as in PSP. This form that was the classical one is now described as corticobasal syndrome. So what they usually have is Parkinsonism that is in one side, as in Parkinson's disease. But they have that ideomotor apraxia, that difficulty knowing how to do things. They have also rapid shirks, the myoclonus. I'll show you some of this. They have the dystonia that is unilateral, like a hand that gets in a stuck position. And they have the alien limb that is like they have difficulty recognizing their own arm or their own leg as their own arm or leg. And that may move, but they are not in control of that. So how is corticobasal degeneration presents? So the corticobasal syndrome, as I mentioned, but there is also a form that has mostly or only initially problems with speech. And that is what we call aphasia. And that is like the patient is unable to have a long way of saying things. People that were very good at expressing themselves suddenly start, or suddenly not, but progressively note that they're having difficulties doing that, that they have difficulties putting together a sentence, that they're having difficulty finding the words. The frontal dementia that I mentioned, the difficulty with being as outgoing, the difficulty as manipulate, the difficulty as being able to do multiple things at the same time, the difficulty in having problems with planning, etc. And then there is the PSP syndrome, that is someone that presents exactly in the same way as PSP. So you can see now the difficulty that we have as physicians in differentiate these two forms, because there is a lot of overlap in the forms that they present. This is one of our patients
My
that passed
main
away.
problem is my right hand and arm that I can't use.
See, that's the idiomotor apraxia.
When did that start?
I think about 3 years ago.
What did you notice then?
Well, I went to an arthritis doctor for my writing. That it started with my writing. I was losing control of the writing. Then it was hard for me to cut my food. See, I'm right-handed, and it was hard for me to cut my food and to eat with my right hand. The hand started to jump. Not so much shaking as jumping,
As a myoclonus.
and I couldn't control it.
Would you see that at times the hand would be moving on its own and you wouldn't realize that it was?
Yes,
moving?
especially at night in bed. I would wake up and the hand would be up.
That's what
Would
we
you
call
also-
levitation.
Feel at times that your own arm was not your own arm?
The right arm, yes.
As the
Do you
alien
have
man.
any feeling that you're slower than you used to?
Oh, very much slower,
can-
yes.
That's the
It's hard
Parkinsonism.
for me to get in and out of a car.
Any other problems, like visual problems?
No, the eyes are still good. Speech is slow, yes.
Any problem swallowing?
No.
Show me how you would brush your teeth with your left hand.
This,
See, she doesn't use a toothbrush. She doesn't use a,
Okay, close your eye now.
and you can see that that arm may jerk at times, and you can see the posturing that is not like the other one. You can see now the jerks. That's the
How can I-
That's
myoclonus.
the jumping that you were talking about.
yeah.
Mhm.
Mhm.
This is how slow she is. So it's the Parkinsonism.
So as fast as we can do it.
That's the fastest.
And here she has a lot of difficulties even doing that movement, as you can see. That is part of the apraxia. See, she cannot really do that movement. And it's not because of the Parkinsonism, it's because of the apraxia.
Now I can do that better.
So she's rigid in her neck and throughout, and it's
your nose.
more on one side than the other. And you can
Your
see that she
nose.
has some difficulties, and that's also because of the myoclonus that she
Your
has.
nose, your finger.
The right arm,
So I'm touching
the
her.
left arm. The left arm.
So she doesn't feel when I do when I touch her twice.
Okay.
And that means that the sensory neglect that I was talking about, the sensory problems. Here is a dystonia, and this is actually the patient who also passed away. Obviously, all these patients gave permission to show you these videos. And so you can all learn and understand the symptoms. And so he has the dystonia, and he's the one that started not being able to use his hand.
Whenever I do with my right hand, the left hand mimics whatever the right hand does. And then at the same time, the left hand goes against whatever I'm doing. For instance, if I try to cut something, the left hand is continuously shaking, and let me just say, if I lift this hand. Yeah. This hand over here, I'm not trying to lift it.
So that's part of the alien limb. So in summary, you can see that there are no specific laboratory tests that we can use. So we use a diagnosis on the symptoms that the patient presents, the loss of balance, the unexplained falls, then the changes in walking, the problems that are unilateral, motor, the problems in the personality, the apathy, what I mentioned as executive function, the difficulty with multitasking, blurred vision, the eye problems that I show you, that the patient cannot look up and down. At times the eyelid, they have difficulty opening or closing, and they may have this staring gaze that you may have seen, a slurred speech, a decrease in the words, and this non-fluent aphasia that I was mentioning. So how do we manage that? So we need to have a multidisciplinary team, as you probably are aware of, that we do have, and we have a lot of things to do. There is a physical therapy, Corey will talk about that, use of weighted walkers, that is absolutely key, because if you use an aluminum one, you can fall with them. These are weighted. And also, instead of moving immediately as the ones that, are triangular and look similar, but those ones, you have to actually stop them instead of this one that what it looks like a brake is an accelerator. So you can even use it if you're not too heavy to get up and so on. You can also have different swallowing techniques. If you have problems swallowing, like using thickeners, you can do speech therapy. You can use amplifiers of your voice. You can do occupational therapy. You can learn how to transfer if that is a problem. You should have supportive therapy and education, and you should have a social worker as well, because it is important that you are seen with all the problems and all of them are taken care of. So thank you so much for seeing and being here. And now it's time for either Andrea to follow up or Corey, one of the two. Thank you so much.
Thank you, Dr. Lippman. Now Corey will continue with her part of the presentation. Thank you.
Okay, thank you, Andrea, and thank you, Dr. Lippman, for your presentation. As Andrea stated, my name is Corey Troyer, and I'm a physical therapist here with UCSD, and I am board certified in neurological clinical specialty. So that means that I have an extensive background in neurological conditions, and I do work very closely with Dr. Lippman and her team at the Movement Disorder Center. So today I will be discussing physical therapy and exercise in atypical Parkinson's disorders, mostly PSP and CBD. Today's agenda is going to be research updates, then a discussion brief on motor symptoms. Dr. Lippman's videos did a great job kind of describing those. Also the physical therapy implications, what we recommend for exercise, and then some general equipment recommendations and tips. Okay, so I will just start by saying the research that is out there is very limited. It is difficult to research people with these presentations because, as Dr. Litvin stated, it's difficult to diagnose the disorders, meaning that it's difficult to get a large group of people that we can research and really figure out what is best in these populations. But I will go over what is available out there. The first one being a systematic review done by Slade in 2020, so the far left on the screen. A systematic review is basically an overview of all of the research that is out there and available. And what they found was that there was robust evidence was not found for therapeutic exercise in people with PSP. They did report improvements in walking from 2 clinical trials. But their bottom line was that the effects of structured physical activity for people, especially with advanced PSP, are not known at this time. Another pilot study completed. This was done on a group of 20 patients, so very small, and there was no control group, so we wouldn't have a way to compare it, whether to have a control group to compare the intervention to. These people underwent a therapeutic exercise program that was customized for each participant. It included resistance or strength training, along with balance training and walking exercises. They completed this training program 60 to 80 minutes every single day for 5 days a week, and that was over a span of 4 weeks. What they found was that the 4-week rehabilitation program did improve the postural control and balance function in these people with PSP. The outcome measures that they looked at to determine that is listed there. So they looked at the PSPRS, which is something that can be done at the neurology office, a pull test, a Berg balance test, a timed up and go test, as well as looking at gait speed. The third on this slide is a narrative review done by Domenico's team. A narrative review is basically a comprehensive, critical, and objective analysis of all the current knowledge on the topic. They found insufficient evidence to support specific rehab interventions in PSP. They were looking to see if balance training or resistance training or treadmill training, anything specific could improve the impairments in people with PSP. What they found was kind of vague, was that rehabilitation might improve balance and gait impairments, and it might reduce falls in PSP subjects. Another study completed, it was a randomized control trial. Again, you can see it was only 19 adults, and these people, they categorized as suspected or probable PSP. So again, Dr. Litvin alluded to the difficulty we have with diagnosing the population. So if these people were highly suspected of having it, they were able to take part in this study. They looked at balance training combined with eye movement and visual awareness exercises compared to just standard balance training alone. And with that, they found that there was some preliminary findings that supported the use of balance and eye movement exercises to improve gaze control in PSP compared to those that did balance training alone. In addition, there is a single case report regarding an 8-week rehabilitation program for one single client with PSP that used body weight supported treadmill training. The treadmill training sessions were 1.5 hours long, and that was completed 3 times per week. What they found was that balance and gait did improve after the 8-week training program. So they looked at the time the person was able to stand on a foam surface, as well as functional reach, gait speed, and actually the number of falls. So you can see with that kind of brief overview right now, we don't have a large sample size of studies to kind of determine what we should be incorporating for people with PSP in physical therapy at this time. Moving along to CBD. There is very, very limited research, again, for similar reasons, difficult to get a large body of people with this disorder and extensively study them at the same level. So this study is a single case report again, and it was actually looking at the repetitive facilitation of exercises, specifically in the hands, combined with occupational therapy in one single client with CBD. The purpose of the study was to evaluate the improvements in hand functions. After 1 month of their treatment, the patient's difficulties in ADLs decreased. The things that specifically that they looked at were wearing clothes, manipulating objects, and cooking. And based on their research, the results suggested the importance of repetition of facilitation exercises in movements required for ADL for recovery in patients with CBD or CBD-like disorders. No other evidence describing the effects of exercise in clients with CBD was found in the literature. And while the literature on rehab and exercise for CBD is extremely limited, it does suggest that PT can play an important role throughout the disease course. And I will get into that a little bit later. One final study that is out there is, again, a single case report. So this is looking at one single person. This man actually began and was diagnosed initially with CBD and then later also diagnosed with PSP. So kind of a mixed feature presentation on this gentleman. They were looking specifically at the longevity of his exercise program. So he completed a program that was twice a week for 1 hour for 10 years. And the study itself talks about how consistent he was, and he missed very little training sessions over the course of that 10-year span. His program focused on trunk and lower extremity stretching and strengthening, as well as upright balance and strengthening, and then forward and backward treadmill walking. With this training program, he was able to maintain his overall mobility, including balance and ambulation, and show a reduction in falls. In addition, the client just demonstrated a slower than expected rate of brain volume loss over time, given his diagnosis and given his age. So their conclusion was that there is evidence to support the efficacy of a regular exercise program to prolong longevity and maintain function in people with CBD or PSP. Again, you can see how limited it is. We're talking about singular case reports on 2 different people. So it would be great if we can somehow research more so we can get a better idea of what exactly our programs should be including. Moving on to the impairments, again, Dr. Lippman did a great job kind of describing these for you all. This one's nice because it kind of shows the similarities between the 2 disorders, but also kind of separates out what's unique to each one. The impairments in PSP and CBD obviously occur and progress at different stages and rates. The combination of the intensity is going to vary for each individual. With PSP, we know that it's characterized by that rapid decline in executive functioning, and that's typically more pronounced than what we see in CBD. The atrophy in the brain that is affected is the medial prefrontal cortex, the basal ganglia, the cerebellum, and the midbrain. In addition to those personality changes, we have the apathy, the impulsivity, and perseveration, in addition to that vertical gaze palsy, which then again impacts mobility. There is some research in PSP that actually suggested that falls in PSP are a result from the cognitive and ocular dysfunction in addition to those Parkinsonian gait features. Which makes sense. It's a combination of all the things, and we can't just pinpoint the falls and blame it on one single aspect of the presentation. And again, sensory symptoms are usually not present in PSP. With CBD, we have that asymmetric rigid syndrome along with that cortical dysfunction that includes those impairments in executive functioning, language, social behaviors, and the sensory loss. That apraxia and alien limb is very common. And the brain regions affected include the basal ganglia, the prefrontal cortex, the parietal lobe, and the corpus callosum. So with physical therapy, we like to provide this throughout the disease course, depending on where the person is in their disease. Our main goals are to maintain functional and safe mobility for as long as possible, to prevent and limit falls and injuries, as well as educating and training care partners to safely help the person with the disease. Looking at specifics with PSP, we are looking to look at initially eye movement training and compensatory strategies in order to scan the environment before walking, as well as tilting head down, which is typically the opposite of what we do in other conditions. Balance exercises and fall prevention training, wide staggered stance with your ADL performance or just with balance in general can be helpful. And we want to avoid bending low and standing up quickly to prevent that backwards loss of balance, which is so evident in the disorder. With gait training, with those Parkinsonian-like steps, we want to focus on large steps and adequate foot clearance and heel strike. And that's where the treadmill training piece can come into play, and we do use that often. We also want to look at appropriate assistive devices. Dr. Litvin kind of alluded to one type in her presentation. Generally, the swivel-wheeled rollators with brakes work well initially, but that's not something that we usually continue to see works well, especially as the falls increase. We do see an eventual need for a wheelchair or a scooter, depending on, again, the cognition of the patient. Will depend on what our recommendation is for the mobility device. We also look at turning strategies and try to work on ways to safely turn without having those falls, home modifications, and then again, recommending appropriate assistive devices and adaptive equipment. With CBD, again, initially therapeutic exercise, balance exercise, and fall prevention training, and that is effective again in the initial stages. As the disease progresses, we focus on passive range of motion or stretching, especially with that limb that could be dystonic, positioning and bracing to prevent contractures. For the Parkinsonian-like gait features, again, we're looking at focusing on large steps and heel strike to make it more efficient. Again, turning strategies are important. And then looking at recommending appropriate assistive devices. Again, generally those swivel wheeled rollators with brakes that people so frequently have, they only work well in those early stages. The apraxia and the alien limb often interferes with our assistive device use. So that's something to keep in mind. And then with disease progression, we eventually find an inability to ambulate due to that progressive rigidity and the cognitive changes. And then we change our focus to care partner assisted mobility, most of the time with a wheelchair. So general recommendations with turning, again, in both disorders, you want to make sure you're using U-turns in open spaces. Again, if we have tight spaces, that can make the freezing of the gait worse. So we try to keep everything open and spacious to make those nice big U-turns. We want to avoid pivot turns, and we also want to avoid trying to cross over one foot over the other. That can lead to tripping. In the bathroom, use of a shower chair or a back is helpful. Again, eliminating any sort of turning in the shower. If you have to do that, using a grab bar to have something to hang onto. The handheld shower heads can also be helpful. So again, you're not turning around in a slippery area. Use of a long-handled sponge can eliminate the bending over again that we see that we're trying to minimize in these conditions. Non-skid surfaces in tubs, non-skid strips, those are very beneficial, again, to reduce slipping. Also beneficial to keep a clear path from your bed to the bathroom, especially for nighttime toileting. If falls are happening more at night, which we typically do see, because people are getting up and they're rushed and they're trying to get to the bathroom, we then can recommend a urinal or a bedside commode to eliminate the degree that you have to travel for that. And then also night lights. Dressing, you can also dress in a seated position to try to eliminate that loss of balance. And again, I know that some of these things feel like, or what people normally tell me is that, you know, they want to be able to do it the same way that they always did. Our main goal is keeping people independent, but also keeping them safe. So we tend to modify those activities to keep you independent for as long as possible. It just may look a little different than what you're used to. So looking at general exercise, this infographic comes from the Parkinson's Foundation. Again, a lot of our strategies and a lot of our therapeutic exercise and guidelines kind of come from the Parkinson's world, just because there's a lot more research in it. And again, there is some overlap with some of the features and impairments that we see. But keep in mind that exercise can take many forms, and it's going to depend on where you are functionally. So playing with your grandchildren, dancing, walking, gardening, those can all be forms of exercise. Aquatic exercise can also be helpful, especially if you're at risk for falling or have fear of falling. People can move a little bit more freely in the water. Plus, the warm water usually feels pretty good to people. And the trick is finding something that you enjoy doing, and something, again, that you can stay consistent with, like our gentleman that stayed consistent with 10 years of a prolonged exercise program. That would be great if everybody could do that. But again, that's very difficult to kind of keep up. But in general, we want you to maintain your strength, flexibility, posture, and mobility. We know that exercise can improve your sense of well-being, promote cardiovascular fitness, and also reduce stress levels. So again, even just thinking general exercise and not necessarily impairment-based treatments, exercise in general is going to help bring that longevity for a variety of reasons. Again, there are some precautions. If you're standing, please perform them with caution. Have a structure or a grab bar or something that you can hang on to, or have someone present to assist you. You can also modify your exercise to a seated or lying position. And people always ask, stationary bikes are good options, especially the recumbent style. The difficulty is getting people on and off of those devices sometimes, so you might need a little bit of help for that. But again, that is a great way to keep up your cardiovascular health, and doesn't include walking, which may be difficult at a certain point in time. We do have some exercise resources. Ours is listed there on the left. So that class is marketed specifically towards people with Parkinson's. But again, we welcome everyone, and I traditionally teach that class, so you will see my face. There is a link there, and there's also recordings. We try to vary it to general levels of function. So providing modifications if you are, balance impaired, so that way you can still exercise and exercise safely. NeuroLab 360 is actually based out of Encinitas. They also offer group classes, again, specifically for Parkinson's disease, but have the ability to offer those services to atypical disorders. So again, finding a program that you like is going to be most beneficial. Moving on to mobility equipment, the recommendations will change based on your disease stages, and the insurance coverage is going to vary. So check with your individual plan for coverage. We know that as the diseases progress, their care partners must also cope with the changes in their mobility, especially to prevent dangerous falls. And a physical therapist can play an important role in this management, or trying to give you recommendations based on when it's time to maybe start to shift to one of these mobility devices, so we can make the mobility easier and safer. So here are different types of walkers. Again, that front-wheeled, I think you guys can see this. The front-wheeled walker here is your pretty standard one. This one has 2 wheels in the front. That's going to make it a little bit easier to push along. We want to avoid those standard 4-post walkers without those wheels, because picking up the walker to advance it can actually make you fall backwards. We've seen, and there is some evidence that putting like little cuff weights on the front of that walker to try to weigh it down can be helpful. Again, this walker weighs about 8 pounds just on its own, so it's pretty light. But now there are other options available. This walker over here, again, is that 4-wheeled rollator walker. This initially can be helpful, again, in those early stages. It'll make turning easier. We have large wheels and swivel casters. We have those handbrakes that, again, you would have to engage or be able to engage in order to stop yourself. The built-in seats and baskets can be helpful, and they're a little bit heavier at 14 to 20 pounds, but they do break down for transport. The other option, which is again what Dr. Litvin talked about in her presentation, is this U-step walker here. We do typically recommend this pretty often in people with PSP. It's very stable. The majority of the weight is lower, so it provides a lower center of gravity for greater stability. This has a reverse braking system, meaning that you have to hold those brakes to disengage them to actually move forward. So a little bit reverse than what your normal is. The downside, or what I find when we recommend this one, it does break down. It just breaks down a little bit bigger, but still can fit into a trunk or be laid down in the backseat of a car. But it does weigh 30 pounds. So that's something to keep in mind when we think about mobility devices to transport in and out of the car. Again, we do eventually get to the point where we need some sort of wheelchair or mobility device. This one on the left is a transport chair. It does exactly what it's said it is. It's designed to transport. So to transport you from A to B, not necessarily to stay in at all times. And it also isn't well designed to be able to propel yourself. We then have standard manual wheelchairs, which is something everybody's familiar with. We can get footrests. We can also put leg straps on there, especially if we're having difficulty with one side in CBD. Also, we can get seat belts for the wheelchairs to prevent falling out of the wheelchair, and sometimes even wheelchair trays to keep things close to you so you don't have to be reaching out all the time and again, losing your balance. All right, and transfer tips. Again, these recommendations are going to change based on what disease stage you are in. So starting at the top left corner with chairs, we want to avoid low, soft chairs and couches. Those are going to be more difficult to get in and out of. Choosing firm, supportive surfaces as able. Also want to avoid chairs without armrests because again, that's going to make it more difficult to get up, and avoiding chairs with wheels. To help transfer someone from a chair, if you're trying to get them to do it on their own, which is always the best way to do it first, you want to encourage them to scoot forward to the front of the chair. Keep their feet wide apart and keep them under the knees. Try to lean forward and then rise up by pushing on the armrests of the chair. So a common phrase that we use is nose over toes. And you would be surprised maybe at how well this works. So if somebody can't quite remember how to do this, even just getting them to do or reminding them of these 3 directions, or sometimes even just saying nose over toes, is going to make a big difference. If you are trying to assist your partner with this transfer, same thing applies. You want to make sure you do the whole chair transfer technique listed above, and then you are going to stand to the side of them, try to place one arm under their arm and the other around their back, keeping your feet wide and knees bent so you don't hurt your back. You want to gently guide your partner forward and up. So that anterior forward direction is usually what people have the most difficult time with. And that's what makes it difficult in order to get people up and out of chairs. Gait belts, I didn't really talk about that, but a gait belt can be helpful here. So you're not, pushing them or pulling on their clothes. And then lastly, we get asked a lot about bed transfers. That is difficult because it all depends on the type of bed that you have. You can purchase rails and put them on your bed. Obviously, hospital beds can be helpful to help with the mobility, but it's recommended that you talk to your doctor, maybe get an order for physical therapy so we can try out various techniques to determine what works best for the care partner and for the patient. And thank you. I know I went kind of fast, but I wanted to make sure I got it all in with room for questions. And there are my resources.
Thank you so much, Corey. That was great. And we'll be able to provide all those resources and those slides to everybody after as well. So if you have questions about any of that, just look for an email from us. And we do only have a few minutes for questions. I apologize, but please enter them in the chat and we'll take a couple. And then you can always send an email to movementdisorders@ucsd.edu because we did run a little long today.
Sorry, that was my talk.
Yeah.
I just want to clarify one thing is that Medicare pays for only one walker.
Yes.
So if you're buying those aluminum ones, buy them yourself because those will not last for a long time and they are the cheapest ones. Similarly with the rollers, I would suggest that if you really think that you will need stronger walker, that you wait for Medicare to pay them because for 5 years you will be unable to get any other.
Yes, that is a great reminder. Thank you. Oh, Andrea, I think you're still muted.
Yes.
Oh my goodness. Thank you. I'll go ahead and read. We do have a couple questions here. Somebody lives out of state and they see Dr. Lessig. A caregiver here has talked about CBD for rigidity. Any thoughts? I did ask Dr. Lessig in the past.
In terms of exercise or transfers or?
It does not specify, but specifies rigidity. So probably some, tips from you, Corey.
Yeah, so again, with rigidity, especially again, once the disease progresses, we focus mostly on passive range of motion and stretching, positioning. Sometimes if it's in the hand, occupational therapy will get involved and they will sometimes recommend a resting hand splint to try to keep the hands and fingers open. And you want to make sure, again, you're stretching. A lot of times people end up like this. We fight and we do our best to try to keep those hands open. And again, that's for comfort. We want to reduce contractures. Same thing can happen at the shoulder or the leg. So there are, stretching programs and things you can use to try to combat that. Sometimes rigidity in actuality can help sometimes with transfers, depending on where it is. So learning how to maybe use that to your advantage, again, with a physical therapist, hopefully you have someone nearby, they can kind of troubleshoot, mobility issues with that.
What about CBD oil?
I don't have any experience with that.
I don't either.
Okay, that was a question in the chat. Another is there a specific diet that will help?
Not really, although, the idea that the microbiome is important in Parkinson's disease leads to the thought that perhaps diets that would change the bacteria that are in the colon may be helpful, but that has not been demonstrated, and that is also hard to demonstrate. But I think it isn't bad to do that. For PSP, there have been studies with coenzyme Q10. They are kind of positive and negative, but that if money is not an issue, you can get CoQ in the pharmacies, and it's a possibility. The dose has to be high, like 1,200 a day. So that's what I meant by, that is end up being a little bit expensive.
Thank you. How many people in San Diego do you think have PSP?
Well, it is estimated to be around 10 to 15 per 100,000 people. So you need to just think about the population of San Diego and make your estimations. How many go to UCSD? Many, but not as many as we would like to see. Many come to UCSD for therapeutic trials, and many come for services. And I'm happy to see them, not only from San Diego, but also from other states. But I think that there could be many, many more patients that are probably not diagnosed that could have the possibility of getting better care.
Well, thank you. That's all the questions that we had today. So with that, I'll thank all the participants, and of course, Corey and Dr. Litvin, thank you so much.
Thank you all.
Thank you, guys. Bye.
Bye.